Every year, close to 1 million people in the United States experience an abnormal blood clot. 1 in 10 dies as a result. Despite advances in treatment and prevention, blood clots represent a significant public health concern, on par with stroke. Sometimes, clots can be traced to hospitalization, surgery, an illness or injury. But other times, people experience blood clots for no apparent reason. In some of these cases, this may indicate a condition called thrombophilia, where the body's clotting proteins are out of balance, causing blood clots to develop when they shouldn't. One of the most common incidents is when a clot forms in a large vein of the arm or leg, blocking blood flow. This is known as deep vein thrombosis, or DVT. If the clot breaks away and moves to the lung, it's called a pulmonary embolism, a life-threatening event that causes 100,000 deaths annually. The CDC estimates that up to 8% of the U.S. population has inherited thrombophilia, a condition where one or more genetic flaws increases the risk for developing abnormal blood clots. Certain rare forms of thrombophilia can cause more than 80% to have a clot by age 50. But the most common forms of thrombophilia are far more benign, with close to 90% never experiencing a clotting problem. In fact, many live their entire lives without ever knowing they have this risk. And that brings up the question of genetic screening. Modern medicine now makes it possible to easily discover whether you have inherited thrombophilia. But should you be tested?
In the context of thrombophilia, genetic testing is controversial mostly because people don't know exactly how often it will change your medical care, and oftentimes it doesn't. So most of the thrombophilias are considered mild risk factors for blood clots, so they do increase the risk. But in terms of what we actually do about that, sometimes it's limited. And the reason is that most of the time the risk of intervening with using a blood thinning medication, for example, would actually outweigh kind of the harms associated with that intervention would outweigh the benefits.
Amy Kirby found out she had inherited thrombophilia when she was 29.
I woke up on a Tuesday morning and turned to my husband and said, "It feels like somebody beat me with a baseball bat all night. I have no idea what's going on."
Amy soon found out that she had suffered a pulmonary embolism, the result of a blood clot that had traveled to her lung. Because the clot was unprovoked, and because Amy was young and otherwise healthy, a comprehensive genetic workup was immediately ordered. The result? Amy had multiple genetic mutations that would increase her risk of clots for the rest of her life.
You know, initially it was terrifying. It was disorienting. As I said, I was relatively young. I was healthy.
Since then, Amy has been taking blood thinners and making lifestyle choices that have allowed her to live clot-free. But when it came time to have a family, Amy and her husband had to decide whether he should be screened as well.
We had to sit back and ask ourselves what we would do with the information. If he did test positive for any of the mutations that I have, obviously our children would be at risk not only of inheriting one copy, but 2 copies, and that is a more significant outcome if you have 2 copies than just one. But we realized that we were not going to change how we might approach having children just based on that information. For example, it would not on its own tip the balance in favor of pursuing IVF and screening the embryos that were created to see if they had the genetic markers. So we decided not to have him tested at that time.
There's a nink in the sink and a zamp in the lamp, and they're
Since that discussion, Amy has had 3 boys, all apparently healthy. But that begged the question, should her kids be screened also?
Likewise, we have not yet had our children screened. I have made sure to communicate the family history at every occasion with their pediatrician, and certainly any time they may encounter a situation in life where the fact that they may be genetically predisposed to a higher risk of blood clotting, then it will come into play.
The fact is, although thrombophilia increases the risk for blood clots, they are by no means guaranteed. For those with many forms of thrombophilia, the lifetime risk of a DVT is only 6 to 10%.
And so there's a large pool of people that have it and never for whatever reason, never have a blood clot. So it's like a risk factor, like your cholesterol level is a risk factor for heart disease. Having factor V Leiden is a risk factor for having a deep vein thrombosis or pulmonary embolism, but it doesn't mean you're gonna have one.
However, people with thrombophilia do need to keep in mind risk factors that increase their chance of a blood clot. These include surgery, pregnancy, extended periods of immobilization, and the use of hormonal contraceptives or menopause treatments. When people with thrombophilia face high-risk situations like these, steps may be taken to reduce their clotting risk. For example, in some cases, people with thrombophilia may receive an anticoagulant or blood-thinning medication to help reduce their risk or prevent blood clots. In people with a rare form of thrombophilia known as hereditary antithrombin deficiency, special consideration is required, and these patients may actually need a specific replacement therapy during these high-risk times. Why do some people hesitate to get screened? It comes down to the fact that a positive test result doesn't always change the treatment plan.
Hematologists over the last 10 years have kind of shifted away from doing a lot of this testing because we haven't been able to prove from a scientific standpoint that doing the genetic testing influences how long we treat somebody.
And there are other factors to consider when deciding whether to get screened.
Do you want to know something that may or may not mean anything? And I think different people take that information differently. Some people may find out that they have the marker and it really can affect them psychologically, emotionally. They become very fearful of every leg pain, every cough in the chest. Does it mean something else because, oh my gosh, I have this genetic marker? There's also some practical issues with respect to insurance coverage, health insurance, life insurance, disability insurance. Right now there are protections in place for pre-existing conditions. Whether those protections will be diluted or removed entirely, there are simply no guarantees.
On the flip side though, I do think that when you have the information over your whole life, it is something that can come into play at different times. So like for the oral contraceptive decision or pregnancy, surgery, and mobility, those are all important things to know about because they're higher risk times, and you might even do things that are not meaning you use a medication, but using compression socks or things that really don't have a harm. Within the 46th pair of chromosomes, there's this long strand of DNA.
The decision to get genetically screened for thrombophilia can be challenging. But one person who can help, and someone who should certainly be part of your healthcare team, is a genetic counselor.
So with every patient, we go into it with a very open mind and take their own history, take their own family history, and look at what their risk factors are for blood clots. And then we basically talk about what the pros and cons are for them. If they're very uninformed about what those considerations are, we have a conversation much like this where I go through kind of how the information may be helpful and kind of what are some of the concerns that come up with it. And at the end of the day, we actually do leave it up to the patient to kind of make their own informed decision about how they want to proceed.
Genetic testing is an incredibly powerful tool in our care arsenal now, but it is, I think, only minimally understood. It can be very confusing and challenging for somebody who is not up on all the medical literature, and I'm certainly not up on all the medical literature. So having a healthcare advocate who can explain it and understand it and help you navigate what it means on a day-to-day basis is really critical.
Whether or not an individual chooses to get screened, they'll benefit from the fact that medical advances over the last 20 years have greatly improved outcomes for those with thrombophilia.
So I think nowadays that we're more aware of what causes blood clots, we're more aware of the symptoms, and we have a lot more tools to treat blood clots when they occur.
As with any medical condition, the most important thing a patient can do is to educate themselves and advocate for appropriate care.
There's no substitute for a patient who is informed and can communicate with his or her physicians.
For more information on blood clots and thrombophilia, go to stoptheclot.org.